Okay. Hello, everybody. Good evening. Um, I am John Baker. I am the co-chair of the California ACC Prevention Committee, along with Nathan Wong, who you'll hear about momentarily. This is going to be the first section of a series of webinars on prevention. So this is going to be newer lipid management and newer therapies beyond statins. So this is going to be the first of a series. We hope you'll join us for the next of our series as well. We'll be planning on having these approximately monthly, all related to prevention. So, first of all, I want to just give you some background as to how to use your Zoom. So the chat is disabled. So if you want to ask a question, which we do encourage, at the bottom of your screen, you'll see, you just tap the picture, and at the bottom of your screen, you'll see a line that says Q&A. So you tap that if you're using a laptop or a desktop, and then that'll bring up the Q&A section box for you. If you're on a iPad or an iPhone or other type of phone, you may not see the Q&A box at the bottom. It may be at the top. So you look at the upper right center. There's a white box. You tap that, and then you'll see the Q&A box there. If you'd like to use closed captioning, it's also below on the box below, show caption, closed captioning, and you get a text message, a text of the program as it goes along. So that's it for the initial for the Zoom conference. Now, as for the actual webinar, so I'd like to start introducing our panel. So our panelists are excellent in terms of what they are able to do. So I'd first like to introduce Eileen Barsegian. She is an associate clinical professor of cardiology at the Irvine Medical Center at University of California, Irvine. She's an interventional and preventive cardiologist. She is the medical director of the Cardiology Care Unit, CCU, and associate program director of the Cardiology Fellowship Program. Her interests include atherosclerosis, microvascular disease, endothelial dysfunction, and she is a principal investigator for several clinical trials targeting cardiovascular protection or prevention. And actually, one of the clinical trials we're going to discuss in a little bit. Next, we have Nicole Harkin. She's a preventive cardiologist. She's board certified in internal medicine, cardiology, echocardiography, and clinical lipidology. She attended Boston University School of Medicine, followed by residency at Columbia University and fellowship at New York University. Dr. Harkin is a founder and CEO of Whole Heart Cardiology, which is a direct care preventive cardiology practice that provides cardiac optimization through precision and lifestyle medicine in San Francisco. Passionate about preventing and treating heart disease through healthful, sustainable lifestyle changes and deep dive diagnosis, Dr. Harkin works with her patients to create a proactive, personalized cardiac care plan. Dr. Harkin, welcome. Next, we have our speaker of tonight, Dr. Nathan Wong, who is he is a cardiovascular epidemiologist, specialist in preventive cardiology, and professor and director of the Heart Disease Prevention Program at the Division of Cardiology at the University of California, Irvine. He has joint appointments in epidemiology at UC Irvine and UCLA, and population health and disease prevention at UC Irvine. He holds an MPH and PhD degrees in epidemiology from Yale University and is a fellow of the American College of Cardiology, American Heart Association, National Lipid Association, and master of the American Society of Preventive Cardiology. He is the past president of the ASPC, the American Society of Preventive Cardiology, Pacific Lipid Association, and also the NLA, International or Inter-American Heart Foundation, which addresses cardiovascular health in Latin America and the Caribbean. He's also a past chair of the American Heart Association Prevention Science Committee, California Cardiovascular Disease Prevention Coalition. As I mentioned, he's also the co-chair of this committee, the Cardiovascular Disease Prevention Committee of the California ACC. Dr. Wong's research interests include cardiovascular risk assessment and subclinical atherosclerosis. He did pioneering work on coronary calcium beginning over 30 years ago and the epidemiology and management of dyslipidemia, diabetes, obesity in relation to cardiovascular disease, including research on residual dyslipidemia, lipoprotein(a), and cardiovascular disease prevention. He's been an investigator or collaborator for many years with the NIH-sponsored Framingham Heart Study, which we've all have heard of, multi-ethnic study of atherosclerosis and other large-scale studies, and was a co-principal investigator at UC Irvine for the Women's Health Initiative. He's been an investigator for numerous clinical trials, including the antihypertensive lipid lowering to prevent heart attack trial, which is the ALLHAT trial, as well as early statin and more recent non-statin clinical trials. He has also had authored over 400 peer-reviewed manuscripts, co-edited 7 textbooks, including Preventive Cardiology, a companion to Braunwald's heart disease, and is on the editorial board of several cardiology and diabetes-related journals, including serving as a co-editor of editor-in-chief of the American Journal of Preventive Cardiology, associate editor of JACC Asia, and also cardiovascular medicine editor-in-chief of the Journal of Clinical Medicine. He is recipient of the ASPC Joseph Stokes Award for Lifetime Achievement in Preventive Cardiology and Lifetime Achievement Award in Clinical Research from the UC Irvine School of Medicine. So again, I'd like to introduce Dr. Wong, who will be talking to us today about an excellent topic, which is optimizing dyslipidemia, the first in a series of topics around prevention, which again, prevention is going to be one of the things that has multiple therapies that are available to today that you can give to your patients tomorrow. So without further ado, Dr. Wong.
Okay, well, thank you very much, John, and I really didn't want you to read the whole bio. No, we've spent a lot of time on that, and certainly want to welcome you as well as my colleagues, Dr. Barsegan and Dr. Harkin, and thank the California ACC for the opportunity to help host this webinar tonight. Yeah, so anyway, what I first just wanted to say is that we have had a wealth of actually guidelines and which have resulted in lower LDL targets over the last 30 years. And as you can see, since I first got into this field and started working at UC Irvine in 1988, we were happy then if our high-risk patients were, this below an LDL of around 130. But you can see that over the last 30 years, these targets have gotten lower and lower. And now, in fact, with the recent European guidelines and the ACC non-statin consensus decision pathway, we're down to below 55 milligram per deciliter in our high-risk patients. And even in India, some of the guidelines I've been involved in there recommend close to 30 milligram per deciliter in our high-risk patients. So this is kind of a summary of where we stand and the most recent European targets, as well as the ACE guidelines from endocrinology and people with diabetes and ASCVD and extreme risk individuals all pretty much recommend an LDL below 55 in our high-risk patients. And as I mentioned, also in India, even lower targets, even lower than what I said, down to 10 to 15 in those with recurrent events. And in Europe, less than actually 40 if you still have recurrent events. Very important is that we actually begin with assessing our patient's risk to determine the how intensively it should be treated, right? So we use these pooled cohort risk scores that estimate the 10-year risk, and they're really intended to really kind of initiate that clinician patient discussion about the best ways to lower risk. So they're really only meant to be a starting point. And as we go on, we'll talk about other ways, but I did want to point out the new Prevent online risk calculator. So this is eventually probably going to replace our current ASCVD risk estimator that's in the guidelines. This was introduced a year ago at AHA as part of the new cardio kidney metabolic syndrome concept. And they actually removed race and ethnicity from the equation because this has been perhaps shown to discriminate who gets treated or not get treated, this on the basis of the color of their skin. But they have added EGFR as well as body mass index. And in fact, even a social determinant of health, such as zip code, can be added. So for example, my risk goes down to 8%, from 8% down to 4.9%, because I live by the beach in Dana Point and I put my zip code in there. So very, very, this very quickly, just wanted to remind people, right, that lifestyle management is a first step in dyslipidemia and cardiovascular risk reduction. And so this generally involves a DASH or Mediterranean dietary patterns recommended by the guidelines. Perhaps Dr. Harkin, who's an expert in this area, will say more about it. This really focusing on high intake of plant-based foods, fish and seafood, plant-based oils, and limited intake of high-fat red meat, sweets, and sugar-sweetened beverages. Exercise and physical activity recommendations really focus on 150 minutes of moderate or 75 minutes per week of vigorous intensity physical activity. Our primary prevention guidelines in 2018, if we go back to our risk scores that we were just talking about, right? Low risk is less than 5%, where the focus is on lifestyle. High risk, you definitely want to be on risk reducing therapy, such as a statin, right? So we really have to think of our lipid therapies, not just to lower LDL cholesterol, but to lower atherosclerotic cardiovascular disease risk. And then if you're in the borderline or intermediate range, you really especially need to document the presence of a series of risk enhancing factors, assuming you have information, right? So you should always be getting a complete family history, assessing LDL, chronic kidney disease, metabolic syndrome. A complete reproductive history, right, should always be taken to assess for whether the female patient has a history of preeclampsia, premature menopause, gestational diabetes, etc., inflammatory diseases. Certain high risk ethnic groups have been recognized, such as South Asian individuals, as well as African American individuals, elevated triglycerides, and certain biomarkers such as LP(a) that is actually the topic of another webinar in the future that we'll be doing, and low ankle index, high sensitivity C-reactive protein. If the treatment decision is still uncertain, we can consider using a measure of subclinical atherosclerosis, such as coronary artery calcium, right? And generally, if you have, if you're in that borderline intermediate risk range and you don't have significant risk enhancing factors, if you have a calcium score of 0, it's been recommended to consider you could actually avoid or postpone drug therapy unless the patient has diabetes, is a heavy smoker, or strong family history. If you're 100 or higher, this is where you should definitely consider risk reducing therapy such as statins. In secondary prevention, it's just important to point out that not all ASCVD patients are considered equal, right? There's great heterogeneity in risk, and we define those at very high risk as those who have multiple major events, such as if they've had both an MI and an ischemic stroke, or one major event and multiple high-risk conditions, as shown here. And our most recent 2022 ACC expert consensus decision pathway does point out that in our very high-risk patients, if the LDL is still 55 or higher, despite high intensity or maximally tolerated statin, Ezetimibe or PCSK9 is really the first choice because those have been shown to have cardiovascular risk reducing evidence. More recently, as I'll mention in a few minutes, bempedoic acid also has cardiovascular outcomes evidence, and the inclisiran outcomes evidence is still pending, but is due out in a few years. Um, and just wanted to point out that now the National Lipid Association revised its recommendations regarding Lp(a), and it's now recommended that this be tested at least once in all adults and selected high-risk children, as shown on the right side of the screen. And really, the idea is that if you have a high risk level, generally defined as 50 milligram per deciliter or 125 nanomoles per liter or higher, the focus is on overall risk reduction, right? So you know we don't yet have approved therapies for lowering Lp(a), with the exception of apheresis. So the focus is on overall risk reduction, including better LDL control and managing other risk factors. Um, Now, we've had a wealth of statin trials over the last 30 years. I remember when the 4S study was the first to show outcomes data when it came out in 1994. There's certainly many other reasons that contribute to residual risk. We're really going to focus on how we can use additional non-statin therapies to kind of eat away at this residual risk. Many patients discontinue statin therapy within a year, and many times it's because either they get a um, few side effects, and then they hear things on the news or read things on the internet about risk of statins. And it's so important that we, you know, emphasize to them that the cardiovascular risk reducing benefits far outweigh some of the potential risk. We also see very few people are achieving, are actually achieving the guideline recommended targets, like I mentioned, both in primary as well as in secondary prevention. We can do a lot better if we consider combination therapy, and many experts in the field are really recommending that in our acute coronary syndrome patients as early as possible at the time of admission, that we really consider combination therapy from the actually outset, because we're really able to get many of these patients at target rapidly, and they're at highest risk, as we all know, early in the acute coronary syndrome phase. I've never been a real big fan of the Improve It trial because you can see here that it took 7 years for them to show a very modest 6% relative risk reduction in an extremely high risk patient population who had an acute coronary syndrome within 10 days. Nevertheless, this was a statistically significant result. And because of the high risk population, the number needed to treat was favorable. So this is, of course, in the guidelines. But I think had they started with a more stable CAD population, they probably would not have seen the benefit shown here. Certainly, the PCSK9 monoclonal antibodies have really made a major impact since their first release now about actually 9 years ago, back in 2015. They were approved, and you can see that what they do is they they actually block PCSK9, which is a protease of around 700 amino acids that would normally destroy that LDL receptor particle complex and a recycling process, which we don't want to disrupt. So if you have a monoclonal antibody, it does, as shown in the large-scale Fourier outcomes trial, which randomized over 27,000 people with ASCVD to evolocumab or placebo, that there was about another 60% further LDL cholesterol reduction beyond statin therapy. And until this trial, we had never had such a large trial where the median LDL cholesterol got down to around 30. So it's very impressive. There was a 15% relative risk reduction. This is also seen in the Odyssey outcomes trial involving the other PCSK9 inhibitor, alirocumab. A very important message here was that the lower on the lower right graph here, right, the lower the achieved LDL, there was further lowering of risk with no threshold below which you did not see further benefit. So this is some of the strongest evidence we have to support the LDL hypothesis. You can see there was a 31% risk reduction in the approximately 500 people who got to an LDL of below 10. Another new kid on the block, even much newer than the PCSK9s, is actually bempedoic acid, right? So this acts in the same pathway as the statins, which you can see act to inhibit HMG-CoA reductase. Bempedoic acid actually inhibits ATP citrate lyase a few steps above. It's not present in the skeletal muscle, so it does not seem to cause the same myositis issues that statins do. So it really is an ideal therapy for the statin sensitive or statin intolerant individual. Anywhere around 15 to 20% or so reductions in LDL is monotherapy in the patient populations that have been studied. In combination with ezetimibe, it's also available as a combination tablet, and we do see roughly 35% reductions in both LDL and hsCRP. Very, very important for everybody to understand is we now have cardiovascular outcomes data from the CLEAR Outcomes trial that studied statin intolerant individuals and almost 14,000 of them in 32 countries. And you can see roughly about a 15% net reduction in LDL compared to placebo, and that the hsCRP reductions roughly around 20%. The important outcome was that there was a 13% reduction in the 4-component MACE, a 15% reduction in the 3-component MACE. And very, very striking is that there was a 30% reduction in risk of events in the primary prevention subgroup. So this is really a superb, and probably it's really the best evidence that we have for a non-statin for reducing ASCVD risk in a primary prevention population. Remember that ezetimibe and as well as PCSK9 inhibitors, really their evidence is largely limited to the secondary prevention population. Inclisiran is a small interferon double-stranded RNA that inhibits the production of PCSK9 from actually cleavage of the messenger RNA, and therefore there's no synthesis of the PCSK9 protein. And this is administered by the healthcare provider, so it's not available to be self-administered by the patient, but the physician or other provider can help ensure that that the patients, are actually taking it. Therefore, so the adherence may be a little bit better, as I'll show in the next slide. But basically, from injections at baseline, 3 months, and every 6 months thereafter, you're getting approximately 50% sustained reductions in LDL cholesterol. And you can see the vast majority of patients will reach LDL targets of, say, less than 70 or less than 100, depending on what types of patients. There's some observational evidence of a benefit from the phase 3 trials, a 25% lower risk in those on inclisiran compared to placebo, as shown in the graph. But remember that we are awaiting the important cardiovascular outcomes trials from the V1P and V2P trials. We're one of the many sites around the world here at UC Irvine for the V2P trial. Dr. Barsegan is our principal investigator for that. We also see greater adherence, as I mentioned earlier. So after 6 months, we're seeing about 70% of patients on inclisiran fully adherent, more than what was observed for the PCSK9 trials, possibly again because you can make sure as their physician to that they're actually taking it. A little bit about hypertriglyceridemia. We oftentimes will actually forget about this, and we have to realize, like in this example of ACS patients, despite achieving an LDL of less than 70, people with higher triglycerides still had higher risk. And unfortunately, our trials of fibrates and niacin have failed to show benefit. Really about the only thing that works is pure icosapent ethyl. Remember, this is a pure EPA prescription fish oil. And when studied in the REDUCE-IT trial of patients with ASCVD or multiple risk factors and moderately elevated LDL, there was a striking 25% risk reduction. And since this trial, several major guidelines around the world do recommend it for people with moderately elevated triglycerides with ASCVD or diabetes. The mechanism is felt to be probably due to the antioxidant and anti-inflammatory effects rather than lowering triglycerides. Fish oil therapies available over the counter or as dietary supplements, we can't really trust them because we don't know what may be in there. They may have huge amounts of saturated fat, as in this example, and as well as certain contaminants. So we have to caution our patients about this, and they're not regulated by the FDA, right? So we don't have evidence that they actually reduce risk. Lastly, a few words about FH, and the Mona Lisa might be our first case of FH who died suddenly at age 37, and the painting Leonardo da Vinci created shows a possible xanthal asthma as well as xanthoma on her knuckle. This is a condition that in its homozygous form present in probably 1 in 300 to 500,000 people is associated with a 20-fold increased risk of coronary heart disease and causes premature MIs. It's much more common than many of these other genetic conditions. There's certain scoring systems, I won't go into detail here, that are available to assess whether someone has a definite or probable diagnosis based on certain characteristics in LDL. But it's a winnable battle, right? And since a statin error, we have more and more patients live longer. We have newer available therapies, including some that we already discussed, and lamidopide and evolocumab are specifically indicated for homozygous FH. In the case of evolocumab, which is a monoclonal antibody, you get roughly 50% reductions in LDL. So this is just kind of a summary slide that goes through the non-statin therapies that we've been talking about, and really again emphasizing those that actually have cardiovascular risk reduce and benefit. This is very important, and some of the dosagen and the side effect issues are also noted there as well. So to summarize, we've discussed how we can start with the risk calculator to help determine the intensity of treatment, but this is really just the starting point in the discussion. You really need to go through those risk enhancing factors, consider coronary calcium that has the strongest evidence of the subclinical measures, emphasize a heart healthy pattern, and for those with ASCVD, remember a high intensity statin is a standard of care, but yet still less than half of our ASCVD patients nationwide are actually on a high intensity statin. So we really have to get the word out there. And you do need to do a lipid profile to assess adherence. There's great heterogeneity in response. Not everyone on a high intensity statin is necessarily going to get 50 or 60% LDL reduction, and also a one-time LP little a use. And those that are still 70 or higher or 55 or higher, if they're very high risk ASCVD despite statin therapy, really should be considered for a non-statin. And we talked about how the expert consensus decision pathway first recommends ezetimibe or a PCSK9, followed by inclisiran or bempedoic acid. Of course, we now have cardiovascular outcomes data for bempedoic acid, in addition to previous data from PCSK9s, as well as ezetimibe, and the inclisiran outcomes trials are still pending, of course, but they look promising. And for those with ASCVD or diabetes and multiple risk factors, do consider icosapent ethyl therapy. A lot of people, this is not on their radar screen, but the Reduce It trial did show a further 25% risk reduction. So I think with that, just wanted to remind you that the Family Heart Foundation, a very important nonprofit dedicated to increasing awareness of LPA as well as FH, recently launched free screening by a take-home kit that is can be sent to your home or the patient's home, that measures LP little a and LDL by a finger stick test. So take advantage of that. And now I want to turn it over to my close colleague, Dr. Barsegan, who's going to go through a post-MI patient.
Thank you, Nathan, and thank you for such a wonderful and thorough presentation on this important topic. This is a case presentation, and there is audience participation, so there will be a multiple choice question pop-up, but most of the questions that do arise have more than one correct answer. So feel free to pick more than one when we get to the question part. Okay, we're going to start with this 52-year-old man of Asian Indian ancestry who was recently admitted with a STEMI and successfully received a stent to his proximal left anterior descending artery. He has mild stenosis in the remainder of the vessels and is being treated medically for those. His diabetes, he does have diabetes, it's controlled on metformin. He still smokes 1 pack per day and refuses to quit. He has a history of mild hypertension and high cholesterol and has been advised by his primary care physician to work with lifestyle and follow a low-fat diet, and he does not consume alcohol. He is not on lipid-lowering therapy at the time of his myocardial infarction. He does have family history with a brother who had a stent at the age of 48 and a father who died suddenly at the age of 60. Review of systems is not very significant or relevant to this conversation. On admission to the hospital, his exam was remarkable. His blood pressure was above goal at 145/90, heart rate 55, and his BMI was 35. No evidence of corneal arctus, xanthelasmas, or tendon xanthomas. His baseline lipid panel on presentation demonstrated a total cholesterol of 240, HDL 37, triglycerides 172, and LDL of 169. And his discharge medications included atorvastatin 80, an aspirin, and clopidogrel, and lisinopril, and beta blocker was not given due to a slow heart rate of 55. The patient was clinically doing well until about 2 weeks post-discharge when he complained of severe muscle pain in his arms and legs. Upon office evaluation, his statin was stopped for 2 weeks with near resolution of his muscle complaints, and he was restarted on atorvastatin at a lower dose of 40 milligrams. Within 2 weeks, he had, while his initial symptoms, the severe ones, had resolved, he did have the reappearance of muscle aches, but this time they were mild, so he continued on atorvastatin 40 daily. After 4 weeks of atorvastatin 40 daily, his repeat lipid panel demonstrated triglycerides of 152 and LDL of 98. Next, please. So this is a good point to pause and identify our patient. So this is a secondary prevention scenario. And in fact, this patient in particular would qualify as the very high risk category. So very high risk for future ASCVD because he has the one major ASCVD event of the recent acute MI within the past 12 months. And he also has other high risk, multiple high risk conditions. While he doesn't qualify with age, as he's in his 50s, he does have diabetes, he does have hypertension, he is a current smoker. So just either with one major and two minor criteria, he qualifies. 3 total. So here's the question part, audience poll. Where would you like to see his LDL and what would you do first? So answer number 1, LDL under 70. Number 2, LDL under 55. Discontinue his current statin and change him to a lower intensity statin. Discontinue the statin and request approval for a PCSK9 inhibitor as monotherapy. Start ezetimibe as monotherapy or request additional blood work, and for now, have him remain on his current dose of statin. Unfortunately, I don't see the audience response answers. So perhaps a summary. There we go. Oh, there's the questions. We'll give everyone a chance to answer. Okay.
If you see the question box, it's on the bottom of it's those polls so that you can answer the questions that way. Try that again.
I'll move forward.
Yes.
Okay.
Not sure why that didn't work.
Okay.
Okay.
Okay, so again, there's multiple answers here, but mostly because he is a high risk, oh, there we go, ASCVD patient. We have a LDL target that's a little more aggressive.
It's working now, so go ahead.
Okay, I'll give everyone a chance to answer. Is it active? I wasn't able to answer. Okay.
It's active. Okay, about another 10 seconds. Okay, here we go. Here are the results.
Okay, great. This is exciting. So yes, LDL target for high risk ASCVD should be under 55 in this patient. And a second appropriate answer is to request for additional blood work and on his current dose. Remember, he's high risk ASCVD, and nobody answered the discontinue the current statin and lower his statins. And there was some suggestion to discontinue the statin and request approval for PCSK9 as monotherapy, as well as a small portion who answered start ezetimibe. So we'll hopefully move forward on this and answer some of those questions of why one is a better answer than the other. So in this case, we did get repeat blood work, and we'll cover some of those answer choices along the way. His repeat labs demonstrated a vitamin D that was low at 18, thyroid was normal, CK was normal, CMP, including creatinine, was normal. However, his LP little a was significantly elevated at 235 in nanomoles per liter. In this case, cutoff is over 125, and nanomoles per liter is considered an elevated number and is a risk enhancing factor. So given this new information, what is the next step in managing this patient's lipids? Now, in this case, there is one correct answer, but a sequential one, perhaps. Maybe two correct answers.
Everyone should have voted.
Oh,
Here we go.
okay, great. The audience answered appropriately. There are two correct answers here. One is, and we can move probably forward with this, is you can change this atorvastatin to rosuvastatin, which is a water-soluble, a more water-soluble statin, better tolerated, less side effect, lower side effect profile. And of course, when you change it, then you can also lower the dose to improve compliance. And in this case, the question stem moves on to prescribing rosuvastatin 10 milligrams. So of course, once you do that, his LDL was already not at target or threshold when it was on the higher dose equivalent of atorvastatin. So you would add another agent, and so here we add evolocumab 140 milligrams every 2 weeks. So the patient's now on a water-soluble statin at a lower dose and evolocumab, and the patient returns to the clinic after 3 months and his LDL is 95. He admits that he forgets to take his evolocumab and doesn't like to self-inject himself. So what is your best next option? So number one, increase the rosuvastatin to 40 milligrams. Number two, replace the evolocumab with ezetimibe. Number three, replace the evolocumab with inclisiran.
Okay, 10 seconds. And here we go.
Great. So ideally, it would be great if we can get him on a higher dose of rosuvastatin, but he's already demonstrated side effects to a dose equivalent of atorvastatin. So that would probably not be the best next option, but in a perfect world, that would be the right option if there were no side effects. And appropriately, the audience gravitated towards replace the evolocumab with inclisiran, which is a good alternative option in this case, given the compliance with the self-injection. So because he wasn't enjoying the self-injection, inclisiran will allow a hospital or a healthcare provider injection, and it's less frequent. So again, a reminder of the 2022 ACC expert consensus decision pathway for non-statins. In a patient who's high risk, the LDL target's above 55 despite either high dose statin or maximally tolerated statin, ezetimibe or PCSK9 are first line choices of non-statins. And the way you pick between the two is basically what LDL target you need to get to. So while ezetimibe lowers LDL about 16 to 18%, a PCSK9 inhibitor will be about 47 to 57%. So it really just depends on what target you're trying to get to. And then inclisiran or bempedoic acid are alternative non-statin therapies that may be considered. And this is a good place to remind that according to the Lipid Association of India, a 2023 update, if you recall our patient South Asian, if you have diabetes and ASCVD, he would fall in that extreme risk group. And so an LDL target of less than 30 is acceptable. And again, a reminder that in this 6-month follow-up for adherence, the blue bar is inclisiran compliance or adherence after 6 months of therapy, whereas the orange and the yellow are PCSK9. So higher adherence to inclisiran therapy. So this patient remains on and tolerates the rosuvastatin 10 milligrams. He's prescribed inclisiran. He's given a clinic visit that's given at the clinic visit. At month 1 and then at month 3, and he returns to clinic after 4 months, and his LDL is now 50. And some points for discussion are: what else would you do? Should his LDL be lower? Should we do more for his diabetes, although he's on metformin? What about his Lp(a)? And perhaps we can make a comment about emerging Lp(a) therapies. So if you recall, there are new great options for patients with diabetes here. So ASCVD patients with diabetes, you have the options of GLP-1 receptor antagonists, either or SGLT2 inhibitors, and they have proven, there are some that are proven benefit in cardiovascular disease. So without further ado, I'm going to pass the mic on to my colleague, Dr. Harkin.
Wonderful. Thank you so much. Dr. Wong, did you want to talk about the prior case more, or do you want to just kind of move on to this case given time?
I think we should move on to this case,
Okay.
and then people can ask questions the remaining time. I want to make sure you get
Yes.
plenty of time here.
Okay, wonderful. So this next case is a case of a 54-year-old Black woman who presents for routine care, and her clinician begins by focusing on her cardiovascular and her metabolic health concerns. Of note, she is postmenopausal. Her blood pressure is 148/88 millimeters of mercury. She is a current smoker. Her BMI is 32. She does have a history of preeclampsia, but she's otherwise healthy, and she's not on any medications for hypertension or any lipid-lowering therapy at this time. She does report occasional non-exertional chest tightness, and then she also complains of some shortness of breath with moderate exertion. In regards to her family history, her mother has had an aortic valve replacement at the age of 48 years of age and does have a history of hyperlipidemia, but we don't really have much additional details beyond that. She also has a maternal uncle who's had a myocardial infarction at the age of 40. Physical exam is fairly unremarkable. She does have a 2 out of 6 systolic ejection murmur at the left sternal border, no bruits, and her second heart sound is audible. She's physically inactive, and she frequently eats fast food, fried foods, and meat with minimal vegetables and fruit. Labs are fairly normal, thyroid, LFTs, renal function, and as is the urinalysis. So here's her labs that you can see here. Of note, her LDL is 160 milligrams per deciliter. She also has an elevated high sensitivity CRP, and her lipoprotein (a) is elevated at 300 nanomoles per liter. As a reminder, greater than 125 is abnormal. So what is the patient's most likely diagnosis? So number 1, mixed hyperlipidemia. Number 2, familial hypercholesterolemia. 3, elevated lipoprotein (a). And 4, she does not have a dyslipidemia diagnosis.
Answers coming in. 10 seconds. Okay.
Interesting. Okay, so we've got a really mixed bag here. Everyone, we're pretty evenly split between numbers 1, 2, and 3. So quickly tackling a mixed hyperlipidemia. So I don't know if it's possible to go back to her lipids, but Her triglycerides were relatively normal at like 100, I think. There we go. So when we're thinking about mixed hyperlipidemia, we're looking at the rest of the lipid profile as well. Her HDL is normal, as are her triglycerides. So we would not give her the diagnosis of a mixed hyperlipidemia in this case. Familial hyperlipidemia, as was presented earlier, is typically diagnosed when LDL cholesterol is greater than 190 milligrams per deciliter. There's also other criteria, including family history. So that would not be the most likely diagnosis in this case. So mostly her elevated lipoprotein little a is her main lipid disorder that we would give her a diagnosis of at this time. Okay, and so then given that, her clinician is trying to figure out what to do for the next steps. So go ahead and mark your answers here. In this case, there are several correct answers.
One moment.
Okay, I'll start reading them. So number one, calculate her ASCVD risk score to frame a discussion about treatment approach and evaluate for other risk enhancing factors. Number two, perform a genetic testing for Lp(a) variant. Oh, there we go. Number three, perform a stress test or an echo. And number four, cascade screening for first and second degree relatives.
Okay.
Great. So many of you wanted to begin by calculating her risk score. This is because this patient is a primary prevention patient. We're really interested in what is her overall risk so that we can then determine her goals of therapy and what medications we might want to use in her. And also reminding of the risk enhancing factors. She had several: the high sensitivity CRP, the lipoprotein little a, her obstetric history. She had a history of preeclampsia. She has family history. So she has many sort of risk enhancing features. In terms of the stress and echo, also a great choice. She had a murmur, and she's also complaining of some exertional symptoms. So exploring that and better kind of figuring out what's going on there is a great choice as well. And then yes, cascade screening for first degree relatives in particular is always recommended for patients with an elevated lipoprotein little a. Genetic testing isn't all that useful thereafter, so that's not typically recommended. And then as you're doing all of this, how would you first treat the patient? So number one, refer her to a registered dietitian to recommend a heart-healthy diet. Number two, prescribe a statin. Number three, prescribe niacin. Number four, prescribe a PCSK9 inhibitor. And number five, address other risk factors. There are also several right choices in this case.
Time's up.
Fantastic. And no one chose niacin. Lovely. So fantastic. So great. So most people chose referring her to a registered dietitian to recommend a heart-healthy diet. As Dr. Wong presented in the beginning, that's always the cornerstone, particularly in our primary prevention patients, but in all of our patients. While we're doing that, we're also going to be placing her on a statin, given all of the risk factors that she had. I don't know, I guess we didn't, her ACC risk calculator, I think her 10-year risk is 11%. So she's in that intermediate risk territory and certainly should consider a statin. And then, yes, addressing her other risk factors. She has several, namely her blood pressure and her body mass index. Okay, So she returns for a visit 3 months later. We decide to put her on 40 of Prava and some hydrochlorothiazide for her blood pressure. And then her risk score is calculated and it's 11.2%. And then she's also been diagnosed, you got her echocardiogram, so she's been diagnosed with mild aortic stenosis, but her stress test was completely normal. So here's her repeat lipids on, again, pravastatin 40 milligrams. Her LDL is now 120 milligrams per deciliter. Her lipoprotein little a remains elevated. That's a lifetime elevation, so we don't expect that to be changing. And then her blood pressure is better, but still elevated at 138/78. So what do we want to do next? Add a PCSK9 inhibitor. Consider adding ezetimibe, consider adding bempedoic acid, consider adding the combo of ezetimibe and bempedoic acid, screen all first-degree relatives for dyslipidemia, including lipoprotein little a, and then do we want to think about other therapies and other referrals? Oh, wait. Is this? The poll is a little bit is different than the slide.
Yes, correct. It is.
Let's realize that.
Noise may be missing, but yeah,
Okay, so okay, so we'll back. Should we hold those for the following? Do we have a poll for this slide or no?
Let's check.
Here. Yeah.
Do you want me to just present from here on?
Yeah,
Okay.
yeah.
All right.
Yeah.
So I think some of those, this is where we were going. Okay, so we decided to switch her to rosuvastatin. She was on pravastatin, recall. So we're going to switch her to a higher potency statin at a decent dose to get some more LDL lowering. But it turns out she couldn't tolerate that dose. And so she's moved back to the pravastatin that she was tolerating previously. And of course, her LDL cholesterol bumped back up to the 120 milligrams per deciliter. We did at that point decide to get a coronary artery calcium score as well. And she was found to have a score of 100. And recall that this test has been very well validated in asymptomatic primary prevention population for better risk stratifying folks. So given this additional data, I will represent the options of different lipid-lowering agents that you now might choose from. Feel free to switch your answer if this new information has changed your answer. So we've got a PCSK9 inhibitor, various combinations of ezetimibe, bempedoic acid, or a combo approach, screening other relatives, and then also considering other therapies.
Okay.
I love it. A lot of people want to refer her to a dietitian and really focus on lifestyle management, which again, I think given that she has several risk factors, lifestyle therapy is fantastic for addressing blood pressure, residual cholesterol risk, and a lot of her other risk factors. So I think that's a fantastic approach and should be included regardless of what sort of lipid lowering therapy you consider to do. So we have a couple options in terms of, what did I just do with it? So people were a bit split in terms of what they wanted to do next with the lipid lowering therapy. Ezetimibe alone, as well as bempedoic acid alone, are probably not going to be our first choices. Ezetimibe alone is fairly popular and certainly is included in the guidelines as a really reasonable next step. I think, as was discussed earlier, thinking about how low you want to get her, given her coronary artery calcium score, neither of those therapies are going to give you a huge bang for your buck at this point. And so thinking about the combo, ezetimibe or bempedoic acid, would be a great approach. That'll give you about a 40-something% lowering. And again, recall has been demonstrated in a primary prevention population to reduce ASCVD risk. PCSK9 inhibitors, I think, are also very reasonable and certainly could be considered. Again, recall she has an elevated lipoprotein little a. And so while we don't have evidence that lowering LP little a in the context of utilizing a PCSK9 inhibitor, you do get about a 20% reduction in lipoprotein little a, which we hope is also helpful in terms of her risk reduction strategies. And this is just to further emphasize the utilization of coronary artery calcium scans, particularly in patients who are uncertain as to whether or not they would benefit from statin initiation at this time, particularly in that intermediate risk group. I would say that clinically also patients, I think find it very helpful. Hyperlipidemia is a fairly abstract concept, and I think actually, demonstrating plaque, subclinical atherosclerosis on imaging can be very powerful for patients to really get that buy-in and increase adherence. And then obviously it can help you really better risk stratify them as to whether or not you can hold off on statin therapy at this time, or whether or not they're a high enough threshold and they really should think about lipid lowering therapy. And I use both that absolute number and then also that percentile score, I think really giving people a sense of where they're at compared to sort of age and gender match controls is helpful. And then this is just, again, that data showing that risk reduction utilizing bempedoic acid in the primary prevention population, showing a 30% reduction and a number needed to treat of 43.
Okay, great. All right. Thank you, Dr. Harkin. That was terrific. We have a couple questions from the audience. One's from Andrew Cow. How does statin affect level of LP little a? There have been reports of no change or mild increase in LP little a. In that case, is PCSK9 inhibitor the preferred therapy to treat elevate LP little a?
Yeah.
So, go
ahead. I was just going to say that, yeah, so it is, so we do see sometimes an increase in the LP little a with statin initiation. However, the LDL reduction far outweighs that potential increase in the lipoprotein little a. And as I discussed with all of my patients, LDL particles still far outweigh those lipoprotein little a particles. So in terms of your reduction of the atherogenic lipoprotein burden, you're achieving with the statin does reduce cardiovascular risk. I do have a handful of patients who prefer, who would really like to go on PCSK9 inhibitors instead. And if we're able to get them, I'm all for lipid lowering, however it's going to be achieved. But there is some of that that patients have been reading.
Yeah, I completely agree. I mean, there were some earlier meta-analyses that did show, possibly up to 30% increases in LP little a from statin therapy, but more recent ones, it's not really conclusive. And still, I think we have to realize that statins are still firmly entrenched in the guidelines, and in somebody with elevated LPA, more aggressively treating all the risk factors, including LDL with statins, still remains the approach of choice and is recommended by existing guidelines.
Excellent. Okay, so we have a few more questions. If a patient is at goal regarding LDL with a statin, but triglycerides remain very elevated, say over 500, what would you add? Fibrates cause rhabdo with statins and have not been shown to improve cardiac prognosis, and patient could not tolerate icosapent ethyl.
Well, fenofibrate, so the problem with the rhabdo is really with them actually gemfibrozil, but fenofibrate seems to be fairly safe, and you don't have that issue. Maybe the others want to comment more about that, but you if their triglycerides were very high, yeah, you would want to. Most of the guidelines do recommend fenofibrate.
Okay.
And you could also certainly the fish oil therapies, of course, and you can use one of the other fish oil products such as Lovaza if icosapent ethyl is not tolerated, and they are, of course, both indicated for very high triglycerides. There are some newer agents in development, which, for individuals with extremely high levels, which, we will see how those pan out. But, that's sort of my take on it. Maybe Nicole or Eileen, you have other comments.
Yeah, my opinion is the same. Generally, fibrates are well tolerated, and I would maybe go in that case in this situation, depending on what the intolerance is to icosapent ethyl. So if it's like a fish allergy, yeah, I wouldn't try other things. But if it's things like arthralgias, I would probably attempt other agents like Dr. Wong suggested, the other options. And yeah, fenofibrate, I know the creatinine is gonna probably go up. I'm aware of that, and that usually goes down when you stop it. So I'll just I'll check the creatinine after initiating it, but generally it's fine.
Yeah, and I would just lastly say it's depending on how high it is, it's one of the few indications for a truly low fat diet. So I refer to an RD for that.
Okay,
Absolutely.
great. Has there been, this is a question from Nadia Abelhad. Has there been any updates in statin use and breastfeeding lactation? Is it an absolute contraindication?
You can take a stab at that.
Eileen?
I don't know of any updates. I think I would steer away from it.
Okay.
Yeah. Yeah, agree. I mean, I think, again, typically you're talking about, premenopausal young women here who are really low risk in the short term. And how I describe it to my patients is, it's a very discrete period of time. And so we just focus on lifestyle that they're able to do at that time, and then we initiate thereafter.
Excellent. Okay, so we have one more question from Jacqueline Bachta. With regards to adding a PCSK9 inhibitor, how does this relate to insurance approval? Do patient needs to be added on Zetia before attempting to submit approval for PCSK9, or can we just order PCSK9? Good question. Who wants to take that?
Yeah, I think we could both answer it, but for me, I'll try to, if I know I need more than that 16 to 18% reduction, I'll go for that PCSK9. And if I get pushback, I'll make the argument that it's not going to be, trial of ezetimibe is not going to be enough reduction.
Yeah, agree. I think there's several payers that will still require ezetimibe to be on board in addition to a maximally tolerated statin. But increasingly, I really think, especially over the last couple of years, that really has improved. I get less and less pushback from payers. And there's actually a handful of payers that don't even require a prior authorization at this point for evolocumab. So we're moving in the right direction there. I would actually say that bempedoic acid is much harder harder to get through insurance companies at this point. And I even have several that have required me to trial a PCSK9 inhibitor before I can put someone on bempedoic acid. So there remains insurance challenges, but I think for the PCSK9 inhibitors, it's improved significantly. And inclisiran actually has been reasonably easy to get approved as well. And as of last year, actually has a primary prevention coverage as well.
Yeah, and I think it's also worth commenting, that if you have evidence that, say, the patient has significant coronary calcium or an elevated Lp(a), this too can also help facilitate approval.
Yeah, so especially if the coronary calcium score is greater than 300, they'll recognize that as established coronary artery disease.
Right. One comment on that, I would also add that if you can do a risk score in advance and put that in your note, that also helps. If you calculate your risk of coronary events, that also helps get these approved. Any other one with final comments? Okay, in that case, we thank all of you for attending. If you have any ideas for additional webinars, we have several planned, but please feel free to email us or to let us know if you'd like to see different topics or additional topics. Remember, the next webinar is going to be next month. We'll be doing these about monthly. So it's going to be December 17th at 5:30 p.m. So feel free to join us, and thank you for coming.
Thank you.
Thank you.
Thank you so much.
All right.